This will be our presentation on the hematological considerations in the management of ductal carcinoma in situ of the breast. And this presentation is by Ahmed Al-Ishmawi, Mohammed Al-Hassan, Bashir Caspo, and Dr. Lindsay Gold, who is a breast surgeon. For the history of present illness, we had a 51-year-old female with a diagnosis of ductal carcinoma in situ, or DCIS, of the left breast that was diagnosed through a routine screening mammogram. The patient underwent or chose to undergo a bilateral mastectomy with immediate reconstruction rather than a lumpectomy. And the presentation involves 2 weeks post-operation. They presented with left-sided arm swelling, pain, and non-pitting edema extending from the clavicle to the fingers. The only pertinent finding on the review of systems ended up being in the musculoskeletal with swelling and pain in the left upper extremity. Past medical history was significant for skin cancer, hypothyroidism, depression, and anxiety. Their past surgical history had no prior surgeries to the mastectomy, and there was no known drug allergies. The patient was only taking 3 medications in the outpatient setting, which included levothyroxine, Lexapro, and Xanax. The patient did not have a history of hereditary breast cancer. Multiple cancer genes like BRCA1 and BRCA2 were negative upon genetic testing. The only family history was significant for hypertension in maternal grandfather and diabetes in the paternal grandmother. A social history revealed no travel history within the last 12 months, no sick contacts. This patient was a non-smoker, no alcohol or drug use, and that they were premenopausal and never breastfed. In regards to laboratory findings, the CBC results were all within normal limits, and the PT and APTT were all within normal limits as well. In regards to imaging for this case, we start with mammogram, and yearly mammogram is what ended up finding the malignancy. Subsequent biopsies of both left and right breast showed that there was a DCIS in the left breast, and the only thing that was found in the right breast was 4mm group of faint calcifications that were confirmed to be non-cancerous on biopsy. SOZO measurements, which measured the fluid index within the extremities, was then taken. As you can see in figure A, before the mastectomies and reconstructions, the patient's baseline was at 2.8, indicating that there was no increased pressure within the extremities. But after, as in figure B, there was a significant increase in the LDEX score, which is what SOZO uses to measure likelihood for lymphedema, which indicated that there was an increased amount of pressure in the patient's extremity. These exam findings were non-specific, and further testing needed to be done in order to confirm the diagnosis. Let's start with the differential diagnosis for this patient who presented with the left upper extremity swelling and pain after a recent bilateral mastectomy. Given the clinical presentation and the patient's history, we considered 3 main differential diagnoses, lymphedema being 1, cellulitis being 2, and thrombophlebitis being the 3rd. The first one for lymphedema, we thought lymphedema is a common post-surgical complication, especially after procedures like mastectomy, which involves lymph node removal. It typically presents as swelling in the affected limb due to a buildup of lymphatic fluid. Why it was considered this patient had a sentinel lymph node biopsy during her mastectomy, which could have disrupted lymphatic drainage, leading to lymphedema. Why it was less likely, however, lymphedema usually develops gradually over months or even years, and usually not within weeks. The acute onset of her symptoms makes lymphedema less likely in this case. Cellulitis was considered, it's a bacterial skin infection that can cause localized swelling, warmth, redness, and pain. It can develop after surgery sometimes, especially if there was any breach in the skin's integrity. It was considered because the patient's arm was described as warm and swollen, which are hallmark signs of cellulitis. Why it was less likely, despite these signs, the absence of systemic symptoms like fever and the acute nature of her presentation made cellulitis a little less likely. Her swelling was more generalized rather than the localized erythema typically seen within cellulitis. In regards to the 3rd diagnosis, thrombophlebitis, it usually involves inflammation of a vein due to a blood clot, usually in superficial veins. It can also present with pain and swelling along the affected veins. This was considered given her recent surgical history and her symptoms. Surgery is a well-known risk factor for thrombosis due to patient immobility and a hypercoagulable state. Why this was less likely? Thrombophlebitis usually involves just the superficial veins, and in this case, the patient had deeper vein involvement, suggesting a more serious condition. So the final diagnosis ended up being an upper extremity DVT, which was confirmed by Doppler ultrasound, the gold standard for identifying thrombi in the veins. The ultrasound revealed acute DVT in the left axillary and brachial veins, with extension into the basilic and medial cubital veins. The most likely cause of this was a hypercoagulable state post-surgery. The most likely it was a combination of the hypercoagulable state induced by the surgery or even underlying undiagnosed coagulopathy within the patients. The coagulopathy could be associated with numerous factors like factor V Leiden mutation or a protein C or S deficiency should be considered, and all of those tests are currently still pending. The management of this ended up being anticoagulation. They were treated promptly with heparin and transitioned to Eliquis, which is critical for preventing the progression of the clot and reducing the risk for complications like a pulmonary embolism. And we need to follow-up for this patient is crucial because we need to monitor the DVT, make sure it doesn't cause things like lymphedema, which we were worried about earlier. Her only lab findings that we were aware of at the time was an elevated D-dimer, which supported the diagnosis of a DVT, but it's a non-specific marker, so lab results in the future will be really important.